A 61-year-old male presents with swelling in the roof of his mouth. He has no pain, but the swelling has gradually been getting bigger and he's getting concerned. Check out the full case with the surgery today on the open reduction. Welcome to the Open Reduction, your channel covering all topics oral and maxillofacial surgery. I'm Dr. Tom Bolten, and today we're removing a lesion in the top jaw. This patient is a 61-year-old male whose dentist noticed a suspicious lesion on the radiograph at his last appointment. He doesn't have any pain, but he's noticed that the roof of his mouth feels like it's gradually getting bigger. His teeth and the anterior maxilla are immobile and test vital. The labial mucosa and alveolar bone are normal. The anterior palate has a soft consistency superior to teeth 8 and 9. There is no drainage and it's not tender to palpation. I obtained a cone beam CT and there's a definite lesion in the anterior maxilla. This lesion is centered in the midline and does not appear to have any association with the tooth. It is a well-defined unilocular radiolucent lesion. This lesion has the clinical and radiographic appearance of a textbook nasopalatine duct cyst. The nasopalatine duct cyst is the most common non-odontogenic cyst in the oral cavity. It actually has a prevalence of 1% of the population. It arises from embryonic remnants of the nasopalatine duct, the structure that helps join the oral and nasal mucosa cavities in a developing fetus. The cyst can develop at any age, but it's very rare before the age of 10. It usually develops within the 4th to 6 decades of life and has a male predilection. Patients usually present like this one, with swelling in the anterior hard palate. They can be painful and cause drainage, but they can also be asymptomatic like this one. They do not cause tooth root resorption. They can appear relatively small on radiograph, and they can also get very big, several centimeters in diameter. If there is a radiolucency 6 millimeters or smaller in the anterior maxilla in this region, it's considered normal and not a nasopalatine duct cyst. If there is a radiolucency greater than 6 millimeters, then treatment is warranted. There are a few tumors and cysts that can mimic a nasopalatine duct cyst, so just like everything I remove from the mouth, this is going to be submitted to the pathologist for a definitive diagnosis. Treatment is complete enucleation. Thankfully, the recurrence rate is very low. This procedure is performed in the office under local anesthesia and nitrous oxide. After I obtain local anesthesia, I make an intersulcular incision along the palatal aspects of the anterior maxillary teeth. I then elevate a full thickness flap and identify the lesion. Here is the lesion coming into view and some of the contents within this lesion as well. I use a curette to free this lesion from the bone and then a rongeur to remove it. These contents go in the pathology jar. This is also where the artery and nerve are located, so it's important to be ready to deal with an arterial bleed if the artery is damaged. This is a very friable lesion. It tears easily and comes out in multiple pieces. Once I'm satisfied that I've removed this lesion in its entirety, I irrigate the area and confirm there's no bleeding. Here is the empty bone cavity. I then reapproximate the flap and close with interproximal sutures. The tissue went to the lab and confirmed the diagnosis of a nasopalatine duct cyst. Like I said before, the risk of recurrence is extremely low. No additional intervention is necessary. The bone will fill in over time. Thanks so much for watching. Please click those like and subscribe buttons, check out the channel, and also keep an eye on my website, theopenreduction.com, where I'll be posting advanced surgical skills to help you hone your craft. I'm Dr. Tom Bolten. I'll catch you next time on the Bolten Reduction.